All right, so thank you all so much for joining us for today's webinar, and happy Turquoise Tuesday. I am Ashley Polans. I am a senior program specialist at the American Indian Cancer Foundation. Just a fun fact, I've been working at AICAF for 3 years now, and every single year Turquoise Tuesday comes around and I tell myself I'll buy something turquoise this coming year so I can actually have turquoise to wear on Turquoise Tuesday. And here I still sit with nothing to wear. So thank you all for who have from across the country who have participated in Turquoise Tuesday in ways that I know we are all very grateful for. Today's webinar, I am joined by our lovely panelists who I'm going to ask to introduce themselves right now. So I think I'm just going to call on you guys if that's okay. So Jessica, can I start with you?
Hi, I'm Jessica Deaton. I'm a nurse manager at the Oklahoma City Indian Clinic, and I work as the Women's Health Nurse Navigator.
And then Dr. Freeman?
Yeah, Dr. Tyler Freeman. I'm a family physician, but the emphasis of my work is on women's health and pediatrics. I oversee the women's health program at the Oklahoma City Indian Clinic, and then do all of our deliveries with a local hospital called Integris here in Oklahoma City.
Mariah?
Hi, I'm Mariah Johnson. I'm the community health manager at Native American Community Clinic in Minneapolis, Minnesota.
And then Nancy.
Hi, I'm Nancy Pierce. I'm a public health nurse with Fresno American Indian Health Project.
Thank you all so much for joining us and taking time out of your busy days to spread this message about cervical cancer screening. For all those who are joining us today, kind of how this is going to run is Dr. Freeman is going to give us the download on cervical cancer screenings and the HPV vaccine as well. And then we're going to jump right into a Q&A section. The panelists and I have come up with some excellent questions, I will say so. But we're also going to be fielding in some questions from you guys as well. So if you're joining us via Zoom, you can enter the questions into the chat feature. If you're joining us on Facebook, make a comment, and I have some of my colleagues who will be monitoring that, and they will let me know any questions that come from Facebook. So however you're joining us today, feel free to ask your questions, and then I'll make sure to get to at least some of them. Dr. Freeman, can you take it away?
Yeah, so my kind of introduction to our conversation today is just to talk a little bit about cervical cancer, the incidence of cervical cancer amongst women. I'll kind of speak primarily in the United States, how we screen for it, and some things that we can do, hopefully, to prevent it. And if we're successful long term, as in some other countries, almost eradicate cervical cancer altogether. So I think an important place to start is with the sort of initial statistics of cervical cancer in the US. The American Cancer Society estimates that in 2021, there'll be over 14,000 new cases of cervical cancer diagnosed just this year, and over 4,000 women are going to die of cervical cancer, which in the grand scheme of an entire population doesn't seem enormous. But when you think that cervical cancer is almost completely preventable with a vaccine that we have but don't use very effectively, it's a shocking number. So cervical cancer is an important part of women's health. It's one of the primary goals that we have in women's health screening, talking about breast cancer and then cervical cancer. But cervical cancer, we primarily screen for through pelvic exams with PAPs. This is something that over the last 50 years, the recommendations of when we should be doing cervical cancer screening changes, and what we should be looking for has also changed as more data has enabled us to be a lot more efficient with screening. But now our guidelines are to start by age 21, and really no sooner. There's not an indication to do cervical cancer screening prior to 21, other than during some pelvic exams for some very specific populations. So in general, we start doing PAPs at age 21 for any woman, regardless of sexual activity or anything else. And in that age group, from age 21 up until age 30, we typically will do cytology only screening, which means that we're doing that pap smear, looking at the cells on the cervix to see if there's any abnormal cells there, any morphological changes that are consistent with precancer, or in some situations already kind of an early cancer staging. When cytology is abnormal, a lot of times what we'll do is reflex, which means the cells look atypical, and so we want to reflexively also look for HPV. That is different from co-testing, which we'll talk about for our 30-year-old women. But in that reflexive testing, we look for HPV, specifically the high-risk types. When we talk about HPV, unfortunately, it's another one of those viruses that has many different iterations that all have different impacts on women's health, ranging from completely benign with no signs or symptoms to genital warts, or in some women, an increased risk for cervical cancer. About 70% of cervical cancers, especially the higher tier cervical cancers, are related to HPV in one way or another. And realistically, if our data was better, I would imagine that number would be even higher. But so that reflex test that we do for our abnormal PAPs between 21 and 30 look for high risk HPV, which allows us to kind of further stratify where their risk is long-term for developing cervical cancer. After age 30, those women are able to do co-testing instead. So co-testing, rather than reflexively going from abnormal cytology to screening for HPV, we screen for both at the same time. And this is a lot more effective at picking up those HPV strands that are going to be putting them at risk for cervical cancer, but B, further stratifying that risk. One of the benefits is we are able to increase that timeline between screening. So for our younger women, 21 to 30, we do cytology with reflex every 3 years. Once we hit age 30, a lot of women are excited to graduate to an every 5-year, typically screening program where we do the co-testing every 5 years. Obviously, there's situations that might change that. So a woman who has an abnormal PAP, whether it's cytology or a high-risk HPV strain, a lot of times they're going to be coming back sooner than that 3 or 5 year window. Most of the time, it's usually annually until we get some normal screening results going forward. So what do we use those PAP results for? Initially, it's just that first layer of screening for cervical cancer. We really don't ever go straight from a PAP to a treatment regimen or anything like that. It's a screening test, not a diagnostic test. So in a woman who's got an abnormal PAP smear, a higher level screening test that we can do is called colposcopy, where a woman comes back for a similar procedure. It's another pelvic exam under a speculum, but it's a little bit longer, it's a little more uncomfortable, and it allows us to take specific biopsies of abnormal areas on the cervix. That's kind of the second tier of screening for cervical cancer in women across the country. I won't go into too much detail of what a colposcopy is or how we perform, because I think that's a little beyond our scope today, but just know an abnormal PAP typically goes to colposcopy, where we get a biopsy that a pathologist is able to look at. And from there, we stage, is this a precancerous lesion on the cervix? Is it a true cancer that needs to be treated now? Or is it somewhere in between and we need to go in and do a little larger biopsy, which is an excisional procedure? So cervical cancer, fortunately, is typically slow growing. And that's why in every 3 years or in every 5-year screening process is typically more than enough for us to catch cancers in a very early stage and treat them. It's why it's so important to emphasize cervical cancer screening in events like Turquoise Tuesday to really encourage women to come in, take some ownership of that health. One of the other big reasons is, especially in women who are in the sort of baby age, and then especially beyond that, the only time that they're coming in to see a doctor is for the women's health visits. And so a lot of GYN providers are the only physician that a woman's going to see for an entire year. So emphasizing cervical cancer when you get them is really important. Treatment-wise, a lot of times we're very, very successful. The reason being we catch cervical cancer early. Being a slow-growing cancer, it typically has not had a chance to metastasize or cause issues where we're going to be unable to treat it successfully in women who've come in to do their screening. So again, really emphasize throughout the entire course of a woman's life how important it is to come in for those routine screenings. Something that I mentioned at the beginning is the HPV vaccine. And it's something that a lot of times we, as a pediatric provider as well, we struggle to encourage parents to vaccinate their kiddos specifically with the HPV vaccine. And part of this is because of a bad marketing strategy at the beginning. When this HPV vaccine came out, they kind of marketed it as a sex vaccine, which it's not what it is, but that's kind of what the initial image was. And for whatever reason, that image has persevered despite some better marketing strategies later on. But what the HPV vaccine really does is reduces or eliminates the lifelong risk of both boys and girls who are vaccinated, or young men and women, of getting these HPV strains that are going to be causing some higher risk features. So it helps to reduce cervical cancer, genital cancer, anal cancers, some oral cancers, even cancers on the penis. So there's a whole lot of different positives to this HPV vaccine that I think people often overlook because they associate it with adverse sexual practices, when in reality, HPV is ubiquitous amongst people who have very few sexual partners. Even then, a lot of times men and women are exposed to HPV. So one of the biggest things that we can do for reducing cervical cancer in the United States is increasing our HPV vaccination rates. If you look at some other countries' data, countries that have made it mandatory or have had a lot more success in recommending the HPV vaccine, their early data on kind of their 20 to 30-year-old women right now, drastically decreasing the rates of cervical cancer. So if we were to make one change in the United States today that was going to drastically reduce or eliminate cervical cancer long term, it would be to increase even marginally our HPV vaccination rates now. When we think about the HPV vaccine, the next question is, when are people eligible for it? Like I said, it's something we typically try to give to our children as early as age 9, but a lot of times we usually recommend it around age 11 or 12. When they're getting vaccinated earlier, it's a 2-shot course. So they get the first shot, they come back a period of time later for a second round. Similar to our COVID vaccine now, we've got to kind of let the body have an initial reaction and then a second dose to sort of boost that immunity. After about age 15, it goes up to a 3-shot regimen. The reason being, it's a little less effective as you get older. So we need that third dose for it to be effective. And for our 15 plus age group, really, we're kind of considering teenagers more so. But for some men and women, especially those who have still been abstinent with no sexual activity, even up to age 26, there's going to be a lot of benefit to getting an HPV vaccine if they haven't had an exposure. However, in your 18, 19-year-old kiddo who's already had several sexual partners, if they haven't been vaccinated for the HPV vaccine yet, I think in a young person, there's still some benefit there, but primarily the benefit comes from being vaccinated prior to intercourse. So kind of more of a clinical discussion at that point for our older patients, especially those over 26, whether or not they're going to benefit from the vaccine. But definitely looking forward at cervical cancer, one of the most important things that we could be working on going forward. So overall, that's kind of start to finish where cervical cancer often begins, how we screen for it, the steps of screening, and what hopefully we can change in the future to help reduce the amount of patients that we have with cervical cancer, reduce the number of women that need a colposcopy, and hopefully, at some point in the future, eliminate it altogether.
Thank you, Dr. Freeman. That was a lot of really cool information. I know I took down some notes. So thank you so much. For those who are joining, again, we're gonna now enter into the Q&A portion of our webinar. So if you're on Zoom or on Facebook, write down your questions that you have, and we'll be sure to make sure we ask them to this really awesome panel. So I guess the first question we have for our panelists, if you guys want to unmute yourself, what challenges has your clinic faced in offering cervical cancer screenings during this time of COVID?
I know for our clinic, we've reduced our appointments availability due to COVID. So that's limiting the amount of women that we can get screened. We've done a pretty good push in previous years so that hopefully most of our women have been screened in the last 3 to 5 years, depending on their age. But we're still just encouraging masks, and if anything's abnormal at all, we're wanting to get them in as soon as possible. We don't want to delay anyone with the previous abnormal or any symptoms of bleeding or changes in symptoms. Those have been red flags for us to go ahead and get them in and make those accommodations.
Ours was similar at Native American Community Clinic in Minneapolis. There was a good few months at the beginning of the pandemic where we weren't doing any physicals, which included PAPs. And so there was, a few months where we we weren't able to do them. And so after that, we had limited availability with a number of providers doing telehealth remotely, and only having one provider in clinic for a good period of time. So so that was yet another challenge as well.
We've always offered transportation to get our clients to and from their appointments, so we're not offering that anymore. So that's definitely been an issue for our clients. And then we've had to, I know a lot of clients are real hesitant to go to appointments. And so I've been really trying to encourage them to still continue to go to their appointments.
Another question we had coming from the audience is, what can health providers do to encourage or make women feel more comfortable receiving their PAP screenings or with HPV vaccines as well?
So I think one of the most important things is trying to develop a relationship or at least some rapport with your patients. A lot of times you'll have people come in for urgent care visits or things that are not necessarily related to their overall public health, those factors of health screening or health maintenance lifelong, and really engaging them in a non-judgmental way of, when was your last PAP screen? Have you talked about cervical cancer or your history or your family history with your provider before? I think one of the biggest things, especially for first timers, so young women who've never had a PAP before, is a lot of hesitancy about that sort of media perception of what they've seen in the movies of what a PAP is like. I obviously have never had one myself, but have done thousands, and I feel like it can't necessarily be nearly as bad as it's often portrayed in the movies. And so I think helping people get past some of that hesitancy is important. But then also a big thing that I help reminds women when I'm like, hey, you're here today. If we do this today, you don't have to have another one for 5 years. If everything's normal, you've got 5 years before you have to come back and do another one. And that, I think, is another sort of important helpful hint to give people to help and encourage them. Okay, I'll just go ahead and get it done today, and then you won't ask me about it for half a decade. So that is usually pretty helpful for some of my women.
Another question we have is, how is your clinic still encouraging patients to receive their PAP tests during COVID?
So go ahead.
No, what I was saying was just, continue to encourage them to go, because, we just have to keep telling them that their overall health is really important. And that's what it kind of boils down to.
I think for our clinic, we have the benefit of some space. We've been able to kind of isolate our clinic into subsections. We have our pediatrics building. We have a dedicated COVID clinic that's in sort of an outdoor mobile clinic that we've built. And so sort of encouraging our patients that when they're coming in to see me or one of our other providers for a PAP, that they're there with other, presumably healthy patients. They're not there amongst a sick patient population. And so any ability that you can give to have patients feel a little safer or a little more sort of separated from what is this kind of gestalt of COVID concern, I think makes people more comfortable and helps to decrease your no-show rates, and also helps to decrease some of their anxiety.
And with our reminder calls too, we're making sure we're letting them know that their temperature is going to get checked when they get to the clinic, that if they don't have a mask, we're going to provide them with a mask. Just kind of reiterating that we're taking all those steps to keep them safe when they're coming in for their visits.
We've had similar experiences here. With reducing the number of providers in clinic, the positive side of that was there was definitely less foot traffic. So women who were coming in for PAPs, you didn't have to worry about waiting in a packed lobby. We limited the number of people that were allowed to wait in the lobby. We also gave them the option of waiting in the car until their visit, and then we would call them. We'd make sure we had a up-to-date cell phone and then call them and then bring them back through one of our side doors, so they didn't have to, they still got their temperature checked and everything, but they didn't have to at least wait in the lobby then if they didn't want to. And then just those reminders, we have a community health worker, and so towards the end of the summer, she was making outreach calls, kind of taking a look at the schedule and proactively catching women who were due, and just a warm reminder that it's still something that we care about despite everything. It is still something we're paying attention to.
And then what measures have your clinic staff taken to ensure patients are safe during their clinic visits, including HPV vaccine visits?
For us, on top of the temperature screenings and the symptom screenings, wearing masks, we've also done as many vaccines outside as we can to try to keep patients from coming into the building. I know a lot of the HPV vaccines in pediatrics were done in vehicles. So the parents would pull up and the kid would stay in the vehicle. So that way the patients aren't all coming into the building, bringing that foot traffic back and forth, and then just being observed and then getting their return appointment. So just trying to kind of think outside the box and create a safe environment.
Yeah, we had similar as Jessica, screening patients before they came in the buildings.
Some other questions we had from the audience. Is there any screening changes for someone who has a family history of cervical cancer?
So typically, no. The reason being is it's very, very rare for a woman to develop cervical cancer before the age of 20. So for every woman starting at age 21, again, with cervical cancer being slow growing, as I said before, typically you're going to start those screening exams at age 21. That would be one of those women that I would encourage, get your first one at 21. And then you continue to go forward with that every 3-year screening, unless there's an abnormal cytology scan, or especially with a reflex to a positive HPV. But in those women, the things that I would do differently, one, as a pediatric provider or even as a young women's health provider, I would strongly encourage her to have the HPV vaccine, before she becomes sexually active. But as far as the PAP screening itself, that routinely shouldn't change unless there's some other factors present.
Okay, and then another question is, what is your clinic able to do to celebrate Turquoise Tuesday this month, or just today in particular?
So I can speak for NAC Clinic in Minneapolis. We are doing a cervical cancer or Turquoise Tuesday bingo. It's open to staff, community members, and of course we always give prizes for the bingo, and so that's one of the things. And then the other thing we're doing this week is encouraging women who are due to call and schedule, and if they call and schedule, then they enter in a raffle. So those are the sort of things that we're trying to do to heighten awareness and also incentivize women in community to engage.
For us here at the Oklahoma City Indian Clinic, we've done some Facebook posts, and I've also ordered some turquoise face masks. So I'm waiting for those all to get delivered, but the patients that get a PAP done in January will get a mask that says 2 times more likely, just to remind them that the American Indian population is 2 times more likely to end up diagnosed with cervical cancer, to help spread the awareness and knowledge. So we're doing that. We're not able to do as much as we would like due to COVID, but we're trying to still raise that awareness.
And then we had another comment come through from our audience. So here's what they say. I understand that there is a HPV vaccine that can be taken for people aged 27 through 45. Although it's said to not be as effective, would you recommend that people who were not vaccinated in their early years take it? And they say thanks.
I guess I spoke on this the most, so I'll take this one too. Definitely, I think there are some people who are going to get a benefit from it. There are some populations specifically who are going to benefit from it. So anyone who is having higher risk sexual behavior, if they're going to get any benefit at all from the vaccine, probably, yeah, you're going to want to recommend that they have that. Anyone who has had no or very limited sexual activity up until age 45, of course, may get some benefit from the vaccine. Like I talked about with the routine schedule, after age 15, they go from a 2-shot to a 3-shot course. And that's because of the reduced efficacy of the vaccine. The older you get, you have less of an immunogenic response, which means that your lifelong immunity to those HPV strains is going to be less. Looking at the data, that doesn't kind of stay the same after 15. The effect of the vaccine continues to taper off. So the further you get past that 26-year mark, the less effective that vaccine is going to be, but still it may offer some modest benefit to someone who hasn't had any exposure. But the biggest factor there, I think, is this person who's considering the HPV vaccine, is it someone who's been sexually active? Because again, once you've been sexually active, despite what people think that I've only had 1 or 2 partners, like I know for sure I haven't had any exposure to it. The reality is that it's a very, very common virus that a lot of times people have no signs or symptoms of. And so if you've had more than 1 partner, your risk of having been exposed to it at some point in your life is pretty reasonable. And the other thing, and I didn't mention this earlier, one of the common things in Oklahoma that I deal with when I'm trying to talk to patients about why I think their kiddo would be a good candidate for the HPV vaccine is religious or cultural objections to it, again, because of that sexual stigma to the vaccine. But what I always counsel my patients about is, regardless of how you've raised your child and what you think their sexual practices are, A, that they may not maintain that, but B, you don't know what their partner has maintained. And so if male or female, they get vaccinated, it helps to prevent them from the sexual history of their partner. Even if they have a monogamous relationship going forward, it could be beneficial. So I think that was sort of a long, convoluted answer to say, yes, I would recommend it. But again, we don't know how effective it's going to be. A lot of the data says the further past 26, it's going to be less effective. And there's some people where even if it is still going to be effective, if they've had some substantial sexual activity, it may not be very beneficial for them going forward. And I think that's also in a perfect world where the vaccines are completely free, whereas within Indian Health, yeah, we're going to have some access to it. But if you're dealing with private insurances at all, even though there's a CDC recommendation up to 45, a lot of the insurances are not adhering to that or not covering that, mostly because of the poor data after age 26.
Another question we had come through was along the same lines of some of the questions we had already developed, which is, What if someone is on the fence about getting an HPV vaccine for themselves or for their children? And we kind of asked ourselves the same question, is how do we encourage others to get the HPV vaccine?
I know that I've heard this said in the past, and Dr. Freeman may be able to say a little bit more to it as far as vaccinating kids. I've heard if you ever plan to be a grandparent, then your daughter should get the vaccine or your son should get the vaccine. I don't know if he's heard that or how much he's heard that, but I know that that's one thing that I've heard at different conferences discussed, speaking with parents about getting that vaccine.
Yeah, I think vaccination in general is always one of those kind of fun topics amongst pediatrics, and then even more so in adult vaccination, just because uh, it seems like over the last decade, and obviously over the last several decades, there's been a lot more suspicion and a lot more sort of research that people and I don't want to air quote it, but research that people have done at home a lot of times that come up with concerns about vaccines. HPV is one of the few vaccines that from a research perspective we know it's effective, especially because of how much social stigma there was with the vaccine early on. There was a lot of hesitancy about, does this cause infertility? Is this just an immunization for people who have had, sex or are going to be having loose sex practices, or is this only for homosexual individuals? And so more than any other vaccine, this has had millions and millions of dollars worth of research, a lot of man hours that have gone into the safety and the efficacy of HPV. So this vaccine for sure we know is safe and is effective. The conversation about vaccination in general, I think it is a harder conversation. There's a lot of great information about motivational interviewing for patients. So if that's not something that you're familiar with, motivational interviewing is kind of a way to help lead patients to making a decision for themselves, helping to kind of guide their decision-making process in a way that includes good information from you, allows you to give some kind of pointers and lead some of your expertise to that conversation without being forceful. That is the biggest part of being successful with a vaccine conversation with your parents. And kind of going back to what I said to an earlier question, is developing a relationship with your patients. And within Indian Health, I think we have a unique opportunity that we have a lot of that cultural buy-in already from Native American or Alaskan Native, individuals coming in to an Indian Health clinic. They feel like they have some of that cultural sort of understanding already. So they already have some of that buy-in, some of that rapport with the fact that they're receiving care within an Indian Health facility. You just have to continue to encourage that relationship, and in instances where you get to see them more than once, try to build on it. And I think that's when, at least for me, I've been the most successful, is with patients where I've been able to have that conversation more than once.
I was gonna add on to that. It's just sometimes I have the luxury to sit down with a parent and really kind of ask them, what are their concerns, and get their feelings on why they're so hesitant, and really talk to them about where they're getting their information from, because it's really interesting sometimes where they get their information and their resources. So it's good to really, kind of narrow it down and find out more information on where they're getting their, like I said, their information from, but and why the hesitancy is so there. Because I've had some parents that are really highly against the HPV vaccine, and it's very interesting to hear what they have to say. But it's good to sit down with them and really talk to them about it.
Another question we have is, what are clinics doing to support screenings and vaccinations over telehealth? How is that working with your providers and your clinics or yourselves?
I can say for our cancer screenings in general, we're trying to encourage our providers to still touch on those discussions and remind them that it's still important to come and get their PAP. It's still important to get their mammogram and their colonoscopy and all of those screenings that they have been getting in the past prior to COVID, and making sure that it's updated in their charts. Just not really letting it drop, even though they're not face to face with the patient, still making sure that that comes up with those virtual visits so that it's still on the patient's mind.
We haven't been doing much of that in our site. I think we will in the future, but right now we aren't doing a lot of telehealth as far as vaccines go, anyway.
And at NAC in Minneapolis, our experiences are similar to Jessica, yours in Oklahoma, where at least we can identify them as due and schedule them at the time of a telehealth visit for them to come in for a PAP and or a lab visit for vaccines at that time.
I know during this year of COVID and everything, a lot of clinics have had to change to adapt to including telehealth as a new service they provide. Do you guys see that as something that's going to continue on past COVID-19, or do you see like the clinic setting kind of altering because of COVID and the here on after?
I definitely do. I think people really, there's a lot of people that really enjoy the telehealth. I mean, I actually do. The doctor's appointments are, they're more specific. Not a lot of rambling goes on. You get in, you get out, and I don't know about the physician at the time. I don't really know about the provider, but as a patient, a lot of patients really like it. And I know the rural areas have the problem, but even in the urban, we're urban, but bus transportation is tough, and it's hard to get a ride to the clinic. And so if they can stay home and get their appointments taken care of, they will choose to do that. So I see it continuing, and we have a large behavioral health component here, and I know our behavioral health really enjoys it too. There are some that definitely need to be coming in, but I see it continuing for sure.
I would say the same thing. I think for us, to some extent, it's broken down a lot of the barriers to care that we have with getting patients in. They don't have to leave work. They can do it during their lunch hour, or they can step outside and do their virtual visit instead of having to arrange transportation to get up to the clinic, have their visit completed. Really taking time off work is a big deal for a lot of our patients, along with that transportation issue. I think that we do try, even with patients that have UTIs or similar concerns. I know I work closely with Dr. Freeman on this, with getting them seen virtually and then coming in for that lab appointment to leave the urine so that they can still get a full visit. The approach is a little bit different.
I would echo all of the above, and then just add to it our experience. I know earlier with the implementation of telehealth, our no-show rate actually went down. I haven't looked at it recently, but we did see no-show rates improved with telehealth, which certainly makes sense. And that's the way we were going prior. It just forced our hand sooner than what we were really capable or thought we were capable of at the time. So yeah, it's not going anywhere.
Okay, we have a few more minutes, so I'm just gonna ask one more question. I don't think we have any more coming from the audience quite yet. But what are some challenges you might have heard about, or challenges around receiving an abnormal PAP?
Sorry, I guess just to clarify, challenges from the patient in like understanding an abnormal PAP or how we're delivering that information? What's
Yeah,
the,
it's not clear, so you could go
okay,
both ways with those.
okay. So, I mean, one of the challenges for a provider with an abnormal PAP is understanding how to interpret them. It's not normal, abnormal. You know, there's a whole spectrum of abnormal cytology from uncertain, you know, up to a low grade, a high grade, various sort of specific cellular abnormalities that you might see on cytology, which can be pretty confusing, especially if you are not somebody who is primarily doing women's health and reading a lot of PAPs. The same thing for the HPV screening. It kind of depends on what lab your facility uses based on how they report that. Some just say high risk present. Some will say, you know, this whole list of HPV types, one of these was detected, but it may not be very specific for you. So one of the best things from the provider side or even public health nurse, you know, whomever is reading these results and giving them out to patients is get the ASCCP app. They've got it for iPhone and Android. If that's not something that you already have integrated into your practice, I really would encourage you to get it. I think it makes a lot of that interpretation a lot easier. They have come up with new guidelines in 2020 that have updated really for the first big time since 2012. The biggest portion of that integrating HPV more into that interpretation of abnormal results, but it essentially spells it out for you. I mean, and it'll walk you through algorithms and all sorts of things for you to sort of continue to learn yourself to a point where you may not necessarily have to look up some of the more common ones that you see. But I think that's the best place to start from a provider perspective. From a patient perspective, when I'm giving out abnormal results, the biggest part of what I want to encourage is one, this is a screening test. You know, the first line screening test is what a PAP is. So we still have to go to a colposcopy, and in that setting sometimes it's going to be completely normal or a low grade change that you don't need to be concerned about. I try to do a little bit of education about the timeline of cervical cancer, so even if, you know, even if on colposcopy we do find some low grade changes there, this is a very, very slow growing disease, and that's why we screened you. And I take that as an opportunity to encourage them and say, you came in and did exactly what you were supposed to do. You know, this is why we do our PAPs routinely, to able to catch this abnormal result early enough that we're able to treat it successfully without really inconveniencing them long term.
I don't know how the other urban facilities work, but for us, we're lucky that Dr. Freeman's able to do those colposcopies in our clinic, and we're not having to send them out to outside facilities. I know our LEAPs and some of the other procedures do have to go outside, so we are, you know, getting those coordination down to another facility and transportation barriers. So those are some added challenges with COVID and needing a COVID test and kind of what the other facilities are requiring.
I know that's a challenge for us, is with the abnormals, we do have to send out for colposcopies. And then there's always a question like, do they follow through? Yes, we can assist them in scheduling. We don't for all of our patients, but even if we assist for scheduling, it's always a question, did they show up? Did they get it done? And then us getting the results back as well. The other challenge that I feel like we have from an outreach perspective, and it just kind of depends on which electronic medical record you have, is when we do a lot of our outreach, we kind of blanket it with the general recommendations. So, you know, every 5 years, it doesn't really take into account if they had an abnormal, it's going to have to be sooner than that. So there's definitely, I would bet, ladies that are falling through the cracks when we even do our outreach, because we just blanket it with, you know, those general recommendations. Our electronic medical records, I feel like, could be a little bit better in having ways where we can generate reports a little bit more easily for when they're due next. Chart reviews can be a little bit tedious that way for some of our community health workers, and finding out when they're truly due if they had an abnormal.
Yeah, we would have to send them out also.
Well, that brings us to the end of our time together. I don't think there are any other questions coming in from the audience. So audience, thank you so much for participating and joining with us today. If you're watching this on Facebook Live after the fact, please keep posting your questions and we will be sure to answer them in a timely manner. We're always looking for more questions from anybody and everybody about what are your questions around cervical cancer or the HPV vaccine. These are really important things to get done. And as Dr. Freeman said, cervical cancer is 100% preventable with the vaccine. Thank you again, panelists, for taking time out of your very busy days to do this and to celebrate Turquoise Tuesday with us. I hope you all have a great rest of your day and please stay safe out there.
Thanks, guys.
Thank you.